Well, good afternoon, everybody, and welcome to yet another one of our Safer Everyday events. This one is officially one of our QI clinics, one of our quality improvement clinics, and actually it was born out of some incidents that we've had in the past where perhaps we've not been the best at being able to identify those patients who may be experiencing delirium rather than maybe dementia or some other complications. So, kindly, Dr. Malik was very helpful by deciding she would present for us towards the doctors actually primarily, and Dr. Malik has actually done this presentation and adapted it slightly for this audience to try and help increase our knowledge and understanding around delirium and what that looks like, how we manage it, how we assess it and how we prevent it. So I'm going to hand over very quickly to Dr. Malik, but before I do that I would just like to remind people to make sure our mobile phones are on silent, and I would ask those who are on the Teams call to just ensure that they leave their cameras off and their mics off, and there is opportunity for questioning, there always is, so anybody on the Teams call, if there are questions that you would like me to ask, please put them in the chat. And I will relay those on your behalf at the end of the session. In addition, Dr. Malik would also like to ask everybody present, so the ones in the room but also the ones on Teams, to consider right now, before we start this session, how much you know about delirium, how much you feel you know. Now, I don't want you necessarily to shout that out, but on Teams, if you could perhaps put a response, that would be great. And then at the end of the session, putting us all on the spot, of course, we'd like to consider whether that feeling has changed, whether you feel you know some more about delirium. Dr. Malik also has a little bit of feedback forms that she would like to sort of just get some feedback. It's always good to get a bit of a temperature check about these things and whether we've met the needs of people. So I'm sure Dr. Malik would really appreciate your input if you could just spare 5 minutes at the end to do that. I'm going to shut up. And I'm going to hand over to Dr. Malik while she presents how we manage, assess and prevent delirium. Thank you.
Thank you, Nikki. Thank you. Hi everyone, my name is Dr. Ambreen Malik. I work at Oberlin Center. The reason I'm making this presentation is mostly because there was a patient on a medical unit and he was delirious. People didn't know at that time that he was delirious. They thought that he was psychotic and they actually moved him over to our unit. And we pretty much right away discovered that he was delirious. We then managed him and he was fine. So after that we thought that we need a bit more education, a bit more awareness about delirium, and I have made a similar presentation to my doctor colleagues, both in surgical teams as well as in the medical teams. And now this one was mostly directed at the nursing teams. However, it has got the same information that it did for the doctor's team. I've just added a bit more for the nursing team. If you have any questions, I suggest that you can ask me in the right in the middle of the presentation. I would prefer it if you kept it till the end. And if you ask me any questions that I do not know the answers of, I promise I'll get back to you at some point afterwards. Okay, shall we start? Okay. So the aim is to assess, prevent and to manage. So what is delirium? Delirium is acute mental confusion starting over a short period of time. So it's between hours to days. Okay, and that you need to remember because that is going to be a differentiating point for most of the dementias as well moving forward. Fluctuates during the day, okay, not just during the day, the night as well. So it's not going to be a constant confusion. There are going to be lucid periods in between. And there's going to be disturbance of consciousness, reduced awareness of environment, and impaired ability to focus, sustain, or shift attention. Do you understand these three parts of attention? Does everybody understand these? Okay. So, in a recap, it's a disturbance of cognition. There is impaired memory. There would be Language disturbance, they might not be able to speak as fluently as they were speaking before the onset. They might not be able to find the right words for it, and they are going to be disorientated. There are also going to be perceptual disturbances. So they are going to have hallucinations. Those hallucinations can be in the form of auditory hallucinations, where you can actually see them responding, talking to people who are not there. It could be in the form of belief that people are after them, or there's somebody coming to get them, or it could be that they can, sorry, going back to the hallucinations, they could also be visual hallucinations. So you will actually see them reaching out for things or people which they believe are there, but they are not. And illusions. Do people understand what illusions are? Okay, illusions are when the thing is there, but you misinterpret it as wrongly. So it could be sometimes when people would be walking in the dark, you might think that there's somebody behind a tree, but actually there would be maybe another tree, another shrub or something. So the thing is there, but you have misinterpreted it. So people with the delirium, they are going to have delusions, hallucinations, and illusions. The first two are related to things that are not there. Illusions are to things that are there, but they are misinterpreting them. Yeah? Okay. And obviously, very importantly, that it should not have any pre-existing or evolving dementia. Because if they have this, then you will have a bit of problem distinguishing between delirium and dementia. I will come to that bit a bit later in the presentation. So far, so good? Yeah? Okay. It is a medical emergency, so it's not a psychiatric emergency. So if you see people like this, they have got these things going on, please remember that they are supposed to be nursed, treated, managed in the medical units. 96% are older people, and out of those people, the older people, the ones who have got dementia are even more likely to have delirium. I got this statistic from Maudsley, Prescribing for Physical Health. It's a book, and it gives these statistics about delirium in older people. 35% of the patients in the medical wards are going to have delirium at some point or another. Did you realize that this was so common? No? Okay. 51% patients in surgical wards. That actually came as a surprise to me. I was not expecting that it would be this high, but apparently it is. Just shows how important it is that we actually diagnose it. Now, it can be brief and transient, so it could be within few hours that it settled down. It may be persistent. Up to 30% can actually last up to a month, and up to 20% up to 6 months. And then there's a percentage that may actually not recover at all. And I'll tell you what we need to do about that as well, again a bit later in the presentation. So why do we need to identify delirium? Again, this is because I told you about the statistics that are very, very high in medical and surgical units. Yes, because of that, but also because 1 in 8 cases are preventable. How many of you knew that delirium was preventable? No? Yeah, it is. So there is also 8-fold increase of dementia within 2 years. 2 in 5 cases would be dead within 12 months. That's significant, isn't it? 1 in 4 admissions to hospital would be delirium. What we underestimate is the patient and carer distress. And by that, we actually should have included the nursing teams as well. I suppose with the carer, we are also including the nursing teams. It can be very distressful for them. There is 20% mortality in 3 years. 20% do not return to the baseline. So even when they recover, they are probably never going to be functioning at what they were pre-morbidly. And there is increased morbidity. So there are types of delirium. If you see there is a baseline of alert and calm, then there is hyperactive delirium, hypoactive delirium, and then there is mixed delirium, which is obviously a mixture of the two. Majority of the cases that we come across are mixed delirium. That accounts for around 64%. Hyperactive is, I think you might have gotten the slide wrong. I think hyperactive would have been 35 and hypoactive would have been I think it's the other way around. For the hyperactive is more than the hypoactive. Anyways, I can take the statistics and let you know. The bottom line is the mixed delirium is the most common type that you're going to have. So what happens in these? You are going to have a very, very agitated, restless, combative patient. And that's the kind of the patient that was sent to us from the medical unit because they could not manage him on the medical ward. So they thought that because he's hallucinating, he's mentally unwell, and that's why he was sent to us. Then there is the lethargic or the sedated or the stuporous type. Stuporous is almost when you're like in a stupor, you're very, very still. That is actually another type of the hypoactive one, and it should be on the I'll confirm the statistics for this one. There is that hypoactive is wrongfully taken as depressed patient. So you might have a patient who's not eating or drinking, is very quiet, and then you just start thinking, oh, he's depressed. No, actually he has got hypoactive delirium. But luckily for us, we have got the mixed type of delirium, which is more common. Okay. Now there's another slide. Actually, it's a mixture of the first one that we have, just the previous one. It shows that you're going to have intense agitation, and there is also fearfulness and paranoid behavior. Now, where do you think that is coming from, fearfulness and paranoid behavior? It's most likely coming from their delusions or from their hallucinations. Hypoactive, very calm, quiet, withdrawn. And then the mixed part is when you are going to have periods of both. Okay? Any questions so far? No? So, who are the people who are at risk of delirium? It's important to know that so that we can prevent it and we can diagnose it early. People of the age group 65 years and more, people who have got dementia. Very importantly, polypharmacy. Elderly people who are on more than 5 medications, 5 or more medications are likely to develop delirium. They are at risk of it. In old age wards, I think that is a very, very common thing to have polypharmacy. Lots of things. It could be for something benign like constipation or something. You would think that's something very, very inconspicuous. But actually, it's the count of the medications. We will talk about the type of the medications that specifically put them at risk even more. If they have got a poor hearing or eyesight, then also they can become a risk factor for delirium because already their sensory perception is limited. Recent surgery, so it could be any surgery, it could be hip related, it could be related to gut, anything. Terminal illness, so you see delirium quite a lot in hospices. And illness of the brain, for instance, if people after they have had head injuries or strokes or infections. Another factor for delirium is previous history of delirium. Yeah? Now, so the more vulnerable you are, even with the slightest of noxious insult, you're going to develop or be predisposed to delirium. If you have got a low vulnerability, so for instance, you do not have all these factors on the left side of the slide, then the precipitating factors are going to be, the noxious insult would require to be a lot more than compared to the highly vulnerable ones. Yes? Okay. Now, what are the causes of delirium? So I'll give you two mnemonics. One is a nicer one, and you have to remember that, and it includes almost everything that you will need. The other one is a kind of a crude one, a funny one, and it does not include all of the things that are included, but it will give you an idea of what you're looking for. So the first mnemonic is pinch me. That is pain, infection, nutrition, constipation, hydration, medication, and environment. So pain can lead to delirium. Acute pain or acute on chronic pain. Yeah, remember that. So if somebody says, I've got pain, or they have had back pain for years, and then suddenly it becomes worse for whatever reason, please remember that it could be acute on chronic pain as well. That could, and you would need to rule out for delirium if they are acting or presenting with the symptoms that we have already discussed. Infections, so it could be urinary tract infection, very, very important in elderly. Pneumonia, abscess anywhere, cellulitis, again very common in the elderly. Gastroenteritis related, hepatitis, encephalitis. The risk, the list is not exhaustive. So any infection anywhere can actually lead to delirium. Nutrition. So it could be hypo or hypernatremia, which is sodium. It could be hypercalcemia, that means increase of calcium. Hypo or hyperglycemia, that's glucose related. Vitamin B1 deficiency. Hypo or hyperthyroid, thyroid related conditions. They can also lead to delirium. Constipation is actually a very, very common cause, and people underestimate. In fact, they don't even consider it a valid reason that somebody would have it, but they do it. They are actually, I've seen elderly patients get so confused and delirious only because they have not passed the poo for, I would say, 4 or 5 days, and they actually become delirious after that. There is also bladder retention. So there are medications that can lead to bladder urinary retention. There could be other conditions, and if that is the case, then people would need to be screening for delirium if the patient presents that way. Hydration. Now hydration is very, very important for hyponatremia as well, that we have discussed above. It could also be related to the glucose control, so they have to be well hydrated. If they are going to be dehydrated for whatever reason, not only is it going to cause all these electrolyte imbalances, but it can also lead to infections like urinary tract infections. It can also lead to constipation. So hydration is actually a very, very important thing. And you might have a history of a patient who has not eaten or who has not drank any water for the last few days. So please be wary of that. Sleep deprivation. Now, sleep deprivation, people who do not sleep well, for whatever reason, it could be related to pain or infection or whatever reason, they can also become delirious. Mobility and falls, immobility and falls. I'll tell you about this a bit later in the presentation. Now, sleep deprivation, immobility, falls, these all come under environment, just in case you're wondering. So it is the E of the pinch me, which is related to sleep deprivation, immobility, and inappropriate noise or lighting. Okay, ready for the crude one? Okay. So there are 5 P's. There are 5 P's, okay. Pain, pee, poo, pills, pus. Yeah? At the end of the presentation, I might ask one of you for the 5 P's. Okay. So, medications that can contribute to delirium. We have already discussed that anybody who is on more than or on 5 or more medications is a risk factor for delirium. Now, which medications on their own can also lead to delirium? Well, alcohol or sedative withdrawal, sedatives and hypnotics, opioids, anticholinergics. So anticholinergics can be things like procyclidine. We have got a whole list of these medications at the next slide, so we can discuss those. Anti-Parkinsonism drugs, antidepressants, anticonvulsants, so that means, anti-epileptic medication, they can also lead to delirium. Steroids, these are also a very important cause of delirium. And we know that recreational use drug toxicity or withdrawal, they can all lead to delirium. Very importantly, you are always going to ask the patient, has there been a recent change in medication? Has it been stopped recently? Has it been increased recently? Have there any changes been made recently? Now, you remember I told you about the anticholinergics? So there is something called an anticholinergic cognitive effect score. And the medications that are anticholinergic and the ones that have got 3 pluses in front of them, trust me, they are more likely to be the culprits for delirium. So these are the names of those medications, and these are the ones with all of them have got 3 pluses in them.
Technical glitch, please bear with us, everybody.
Right. So do you see over here that there are anticholinergic drugs and also there are antidepressants that have got anticholinergic effects, and all of them have got 3+ scores. Now, I believe that most of you are here as the nursing teams, right? Okay, all right. This is really the part that relates to the doctors, and they would be the ones checking those ACE score for these. There is actually a website from which they can check the scores of any medications that they are on. So the anticholinergic burden, again, this, as I said earlier on, that this was also part of the presentation, was for the doctors. And if they have got the anticholinergic medication is the cause, then you are going to see these side effects, or you're going to see this clinical presentation. The patient's going to be confused, dizzy, hallucinating. There's going to be tachycardia. There's going to be urinary retention. Skin is going to be flushed and quite warm to touch. Constipation, dry mouth, and there would be blurred vision or dry eyes. So that was the medications, and that was the risk factors that would be contributing to delirium. Now, how do we assess and diagnose delirium? There are two ways that we can assess them, depending on the settings that we are in. So if we are in any acute setting, nursing homes, even when you are as a paramedic, as a nurse, when you go and visit them, you will use the 480 method. The second one is only used when the patient is in ICU. Okay. Now there are the screening tests and the clinical judgment. The two screening tests that I told you about, they are not diagnostic. The diagnosis is going to come from the screening test plus your clinical judgment. There is no screening test yet for delirium that would actually tell you yes or no. You also have to have the clinical judgment added to the picture. So these screening tests are from NICE guidelines, and it is 480, which is in acute settings, and the one in ICU settings is called CAM ICU. That's convenient, isn't it, for you to remember? CAM ICU for ICU settings. 480. Yeah. So what are the 4 A's that you're looking for? 480. Looking for, are they alert? Abbreviated mental test, I'll tell you what that is. There's attention. You will be asking them for the months of the year backwards. And acute change or fluctuating course. So are they going to have a lucid period followed by a disorientated period or not? So 480 can be scored in patients even if they are too drowsy to answer. That's interesting because you are going to come across delirious patients who may not respond or who are too drowsy. So there is no patient at all that you will not be able to use 480 on. So in that way it's quite helpful. However, as I said earlier on, that it is not the diagnostic criteria. It is just a screening tool. You will be basing your diagnosis on your clinical judgment as well. Okay, let's talk about 480. Alertness. So you can rate them up to 4. If the patient is asleep, you will gently wake them with speech or touch. Okay? If they are fully alert, then it is a 0. If it is impaired, then it is a 4. Yeah? Abbreviated mental test, and it is rated up to 2. So you can give a maximum marks of 2 for that. You will ask them 4 questions. So there's going to be age, their date of birth, the place, and the year. So where are you right now and what year it is? If there is no mistake, it's a 0. If there is one mistake, then it's a 1. And if it's 2 or more mistakes, then it is a 2. Yeah? Okay. Then there is the attention that you will be checking, and it is rated up to 2 maximum. So you will be asking them for the months of the year backwards. And if they give you up to 7 or more, then it's a 0. If it is less than 7 months, then if it is a 1. And if they do not even start saying the months, yeah, because they're too drowsy or they cannot follow your instructions, then it will be a 2. Acute change of fluctuations. Evidence of fluctuations in alertness, cognition, hallucinations, evidence in the last 24 hours. If you have not had any in the last 24 hours, it's a flat 0. But if you have had these, then it's a yes, it's a 4. Any questions so far? So this is actually the 4AT. Yeah? 4 A's and T is for the abbreviated mental test included. Again, it's a mild, this is another way of telling you how to do 480. Alertness, normal, not agitated, 0. Again, they might be sleepy. If you wake them, after a while they get alert, that's fine. And if it's abnormal, alertness, then you give them a 4. AMT 4, we have already discussed that if there is no mistake, it's a 0. If it's a 1 mistake, it's a 1. And if it's a 2 or more mistakes, it's a 2. For attention, 7 months or more, it's a 0. Less than 7 or refuses to start, that would be a 1, and it does not start. That means that they are not able to follow your instructions, then it's a 2. Acute change in fluctuations, that is in the last 24 hours. Either they have it or they don't have it. If they don't have it, then it's a 0, and if they have it, it's a 4. Any questions? Okay. So 4 or more suggests delirium, but it is not diagnostic. In every case, the diagnosis is reached by clinical judgment. 1 to 3 would be cognitive impairment. So you will need more detailed cognitive testing, and you will need more information taking, it may be indicated. 0, it does not definitively exclude delirium or cognitive impairment. That's interesting, isn't it? Not very helpful there. But at least let's focus on the first 2 bits, 4 and 1 to 3. Yeah? That gives you a direction where to go. Okay. The 480 was designed as 4 out of 12 or more that can be reached in several ways and in different settings. It could be with informant history or without informant history. And always a diagnosis of delirium should not be delayed if it is difficult or impossible to get the informant history. So don't wait for XYZ to arrive at the hospital. If you think that the patient is unwell, please start investigating them. CAM ICU. That's complicated. I don't think many of you are going to be using that. I think the best way forward would be really to just focus on the 480, but it is there if you need to ever go back to it. It's called Confusion Assessment Method for ICUs. Right? Right. So, how many of you knew that it was preventable? Earlier on, somebody said no one. Okay, yeah, good. So, well, good news is that it is preventable in some cases. Do you remember that statistic earlier on? It's preventable in 1 in 8 cases. So, how do we prevent delirium? So, NICE guideline says that within 24 hours of admission, assess people at risk for clinical factors contributing to delirium. So, who are those people then? Do you remember that list. So NICE guideline says that within 24 hours of admission, please assess these people for delirium. Yeah, shall we go back to prevention? So now we know which people we should be assessing for clinical factors that can contribute to delirium. Based on the results of this assessment, provide a multi-component intervention tailored to the person's individual need and care setting. Very important. We will discuss that in a bit, that how is it multi-component and how is it structured to the person's needs. And it should be delivered by an MDT trained and competent in delirium prevention. So, where possible, we should ensure that the people at risk are cared for by professionals who are familiar to the person at risk, and that is a NICE guideline. It's very important again for the person to feel reassured. If they are disorientated and they have got new faces coming in and out of the room all the time, it's not going to be helpful. Avoid moving people within and between wards and rooms unless absolutely necessary. So if you think that there's somebody who is at risk of delirium, please do not shift them from bed bay to bed bay or from room to room. I do appreciate that you all have got bed pressures and it's not an ideal thing, but try, that's all I can say. Right. Do you remember that pinch me? Yeah? Okay. So those who are in pain, assess for pain. If the patient is in pain, look for non-verbal signs of pain, particularly in those with communication difficulties. For example, those with learning disability, dementia, those who are on ventilator or with a tracheostomy. So what are the non-verbal signs of pain? Sorry, grimacing, yeah, that's another one. Hands, yeah, they might be agitated, or there may be body language that would actually indicate to you that they are in pain. Start and review appropriate pain management in any person in whom pain is identified or suspected. So obviously for pinch me, P part, which is the pain, you would want to give them pain relief sooner rather than later to prevent them from getting into a delirious state. Next is infections. So you look for and treat infections. Avoid unnecessary catheterization. In old age patients, catheterization can very quickly lead to delirium. So try to avoid it as much as you can. Implement infection control. Okay. Nutrition. So there are NICE guidelines for nutritional support for adults. I did not go into detail for them. If the patients have dentures, ensure that they fit properly, because they won't be eating, would they? Yeah, and how is that going to affect their fluid and dietary intake? So make sure that something as ordinary like dentures, that can also end up with them getting delirious because they have not eaten or they have not had a drink properly. Hydration, again the same thing, ensuring adequate fluid intake to prevent dehydration. Consider offering subcutaneous or IV fluids if necessary. Take advice when managing fluid balance in people with comorbidities, for example, heart failure or chronic kidney disease. So we we have discussed earlier on about the ACE score, which was the anticholinergic cognition effect. So there has to be a medication review for people taking multiple drugs, both on account of the type and also for the number of the medications. Environment. So appropriate lighting and clear signage. A 24-hour clock in ICU, a calendar which is easily visible to the person at risk. Try to talk to the person, reorientate them to who they are, where they are, and what your role is. Now, please remember that this is something that we are doing to prevent delirium. And this is the same thing that you will carry on doing even when the patient does become delirious. And at that time, you are going to do it in a slightly more in-depth. Introduce cognitively stimulating activities, for example, remnants. Okay, so I've seen nurses, my personal experience is that when somebody is not well and they want to distract the patient, they start asking them, where was the last holiday that you went to? Or when did you last go for XYZ or something? And then the patient starts talking about those things. So what you are doing is that not only are you distracting them, but you are actually also reorientating them to who they are. Regular visits from family and friends. That is an important bit. And that is not only to prevent delirium, but also to manage it later on. Resolve any reversible cause of impairment, such as an impacted earwax. Now, remember what we talked about constipation, how elderly people can actually become delirious because of constipation. If they have got sensory impairment because of that's affecting their ears or eyes, or that can also actually contribute to them to have delirium. Mobilize soon after surgery, walk, and by walking, if they need walking aids, by all means use those. Make sure that those walking aids are at their hands, at their arms' length, so that they can reach out to them. Encourage all patients, including those unable to walk, to carry out active range of motion exercises. So how is the last part going to help prevent delirium? How is the last part going to prevent delirium? How is the mobility, improving the mobility, going to prevent delirium?
Prevention of constipation.
Yes, constipation, improvement, yes. Prevention of strokes. Yeah, yeah, okay. So you would be assessing for hypoxia, and you would be giving them oxygen saturation that is as required. And some pulse oximeters can underestimate or overestimate oxygen saturation levels. Did you know that overestimation has been reported in people with dark skin? How many of you do that? So if you use a pulse oximeter on a dark-skinned patient, it actually may be giving you false results, and it may be giving you a higher reading. I asked that from my medical colleague cohort, and I think only one of them was aware of it, not the others. Okay. Yeah. Avoid nursing or medical procedures during sleeping hours if possible. Schedule medication rounds to avoid disturbing the sleep. Reduce noise to a minimum during sleep hours. And this is all prevention. of delirium. Now, safe subscribing to avoid delirium. We have already talked about the anticholinergic medications, so we have to protect the acetylcholine. Otherwise, it can lead to hallucinations and delirium. Support sleep at night, but not the use of hypnotics. Do not give sedatives and hypnotics to people at risk if you can avoid it. Otherwise, they will end up delirious. If pain is identified, paracetamol is the first choice. Remember why? Because opioids was one of the medications that were leading to delirium. With medications, start low, go slow. And this is especially for frail patients. Avoid rapid medication withdrawal for high-risk drugs. Optimize medications. Remember what we discussed about 5 or more? Remember that one. So optimized medication means that instead of giving small doses of 2 similar medications, why not stop one and increase the dose of the other one? So you are optimizing the dose, but you are also reducing the number of medications that the person is on. High-risk drugs. We have already seen a list of those drugs that have got ACE score of 3+. So they should either be stopped or they should be reduced. And then reduce the reliance of antipsychotic medications. That is again to prevent delirium, and antipsychotics would again be one of those medications that can lead to delirium. Over-the-counter medication. Right, cocodamol, codeine related, yeah, Piriton, Nitol, all of them have got these effects that could lead to delirium. This is just a recap of what we have discussed earlier on. One of the things I would say that is extra over here is that you will be asking them about alcohol, because we have spoken about alcohol withdrawal that can also lead to delirium. Yeah. Shall I move on to the next slide? Okay, so now we know who are the people who are at risk of delirium. We now know how we want to screen them for delirium. We have also discussed how we can prevent it. Now let's talk about what do we do for somebody that we know is now delirious. So let's talk about what we should not do first. If the patient is delirious, try not to catheterize them or cannulate them unnecessarily. Do not argue with the patient. That is okay, they are already very confused. They don't know what's going on in their head. And if you are going to be adding to the stress by arguing, so if they say that they can see something in the room, do not argue with them. That no, you can't. Do not argue. Do not change wards, bays, rooms, especially at night. Yeah? Do not approach them from the side where they cannot see you. They are going to be in a very difficult place when they are delirious, especially if they are hallucinating. They are going to feel that they are at risk. And if you are going to approach somebody who's already very scared, that's not going to help the situation, is it? You should always approach them from where they can see you. Make sure that you introduce yourself, calm them down, Show them your badge. Tell them that it's going to be okay, it's only temporary, it's going to pass. And please do not keep waking up the patient. And do not order tests that you do not routinely do, unless indicated. So, investigations. There's a whole lot of investigations. The first slide is related mostly to the ones that are related to blood only. So, do you want me to discuss this in detail or no? Okay, that's fine. So, the second slide is also related to blood testing, and there's a whole list of. The third slide is, other than blood, what do you check? Urine dipstick, you should check. ECG, chest x-rays, CT, MRI, lumbar puncture. So always, first of all, complete the non-invasive investigations before you go into the invasive ones, like lumbar puncture. Okay. Right, so these patients should be managed in general medical settings with input from appropriate medical or surgical subspecialties. Identify and treat any potential cause. Provide supportive and symptomatic care. Patient often lacks capacity, so you consider DAWLS or the Capacity Act. I believe that the Capacity Act is coming up in a few weeks or months in Guernsey. Yeah? DAWLS is something that my understanding is that it would be somewhere in like care homes. Right. You know, the second point where it says identify and treat any potential cause. Remember that there may not be just one cause, it might be multifactorial. They might have more than 5 medications, they might have an infection ongoing as well, they might have problems with their hearing or something. So it is just, don't think that one factor is solely going to be responsible for delirium in every case. There might be more than that. Very importantly, medication is not the first line of treatment. So the things that you are going to do, we are going to be talking more about the non-pharmacological management of delirium. So first of all is the behavior. Do provide reassurance, do provide instructions simple, identify any unmet needs, for example, thirst, identify specific triggers, for example, certain sounds or people. So if they are, in case they are hallucinating, yeah, they might think that a certain person or staff member is part of that hallucination or their delusions. Identify that what makes them worse. If there's any certain noise, if they're a certain person, that makes them feel worse when they enter the room. Give the choice to make their decisions regarding clothing, food, and bathing. Already the person is very distressed because of their experiences. So make sure that you give them as much autonomy as you can do reasonably. Encourage patients to talk about what they can see when they are calmer. So remember, I told you that there are going to be periods of fluctuations of lucidity and delirious or psychotic or agitated behavior. When they are calmer, ask them, what was it that you could see? What was it that you could hear? What is it that you need help with? And always keep repeating to them that it is only temporary, it's all right, it's going to pass, it's going to pass. Do not make them do something that they don't want to. For instance, if they don't want to take a bath, but you think it's their bath day, please do not drag them to the bathroom. Do not force them with anything. Do not challenge their abnormal beliefs or hallucinations. So if they are talking to someone, don't say, oh, there's nobody there, there's nobody there. They are already very agitated. Just give them some space. Let them experience it, but keep reassuring them. Now, we discussed about the behavior. Let's talk about the environment. So you're going to introduce yourself and your role, and that might be necessary every time that you enter the room, depending on how delirious the patient is. You should have your identity badges. The lighting should not be too dark or too bright. It should not be too hot or too cold. There should be signs on doors. So if they have got an adjacent toilet, it should say that it's a toilet. There might actually be, you might need signs for drawers even. If they're that disorientated, they might need signs at lots of places in the room. We need to let them feel as orientated as we can. Ask the family if they can bring any photographs, if they can bring any books or any plants that the patient is used to having. 1 or 2 would suffice, and provide it to the patient so that they have got something to anchor themselves when they are disoriented. Sensory. So make sure that the glasses that they are wearing are theirs, not somebody else's. That's not going to help. Make sure it's clean. Hearing aids, make sure that it's on, the batteries are working. If appropriate, hand massages. I don't know how often you guys do it, but in psychiatric wards, it actually helps patient calm down a lot. Pain. So you look for pain gestures and give pain relief. Yeah. So far, it's all non-pharmacological. Okay. Food and drink. Encourage them to eat and drink. You monitor the quality of the fluid intake. You know, people say, if when they give handovers, they say that, oh, so-and-so had some juice, had some this, some that. No, don't be vague. Just give the quantity. We don't want to know about the quality of the fluids that they are taking. We want to know the quantity, and it should be enough to keep them hydrated. Again, dentures, make sure that they fit, they are there, and see if they've got any problems swallowing. Is that the reason why they became unwell in the first place? Because they were not eating or drinking in when they were at home. Continence. There has to be a toilet program, and that is recommended by NICE. I'm assuming the nurses know what toilet program is. Okay. Assist the hygiene, and then monitor for UTIs or constipation. If at risk, going back to constipation, so just imagine that somebody has come in and they are delirious for some other reason, okay? They are delirious because of opioids. But they actually might have constipation because of the opioids as well. So do not just focus on one thing. Go through the whole list that what else could be happening in the body. Because like I've said before, delirium is mostly multifactorial, not just one thing. Mobility, if at risk of falls, you nurse them at arm's length. Footwear, please check that it is not too tight or not too loose, because they might not be able to tell you later on. Mobility aids, make sure that these are accessible to them. Non-pharmacological management, and that is, we come to the last part, which is how can we use the family to help with with a delirious patient. Life story document, which is like, this is me. So it can be pictures of familiar people, familiar places. It could be postcards. It could be something that actually anchors them to their life. Familiar objects, favorite foods and drinks. Ensure that the family are reassured that this is temporary. So imagine that there's a family that has no experience of any mental illness or any such cases before. Guess how scared they would be that, look, we brought our mummy here. She was fine, and look what you have done. Look at how she's behaving now. So please keep reassuring them that they're going to be fine. Now, this is something that I took. It is basically all the things that we have discussed, but it is like in a pinwheel. Okay. It will be available in the slide. Okay. Now, those slides, I have just elaborated them a bit more for you all. So you will be optimizing. So you would be considering one-to-one obs if there's a risk of falls, or you would nurse them at arm's length. You will orientate them. There's going to be hydration, nutrition, hypoxia, and pain control that you would be optimizing them for. You will orientate them for communication with staff. And there's gentle reorientation. So it's like, it's lunchtime. It's dinner time. Come on, let's go this, let's do this. Do not assume that the patient is going to know that it's lunchtime. They are going to be totally off it for some time. And reassurances, again, that you are safe. It's a very, very scary experience for the patients. And you want to reassure them about their safety. And you can distract them. So if they are, for instance, if they are responding to auditory hallucinations or visual hallucinations, you are not going to challenge them, but you can distract them and say, can you see me? Try to bring them back to reality without actually challenging them. Visible clocks, you want the 24-hour clocks, you want the big day calendars, clear signage, familiar items, family and friends to visit, and you have to give psychoeducation first to the family. Adequate lighting and temperature, reduce noise, correct any sensory impairment. And you will be encouraging mobilization, and it would be under supervision. Right. In distressed and agitated patients, what do? There would be use of non-confrontational and empathetic de-escalation techniques. Involve security if you feel at risk. So this particular patient that I had mentioned earlier on, who was transferred to us from the medical unit to a psychiatric unit, I think that the breaking point for the staff at the medical point was when this particular patient tried to jump out of the window. That was traumatic, not only for the patient but also for the staff. So you would involve security if required. And then there's the pharmacological management. I shall go through that quickly. Again, we've discussed about the review of all the medications with the ACE scores. And polypharmacy should be avoided completely. A medication review. And again, as I mentioned before, there's this association between polypharmacy and the persistence of delirium. And there are studies in it which actually say, please do not do it. It's going to prolong the delirium. Okay, and The only time that you would consider giving medications for the patient is that you are going to, if they are risk to self and others, if they are in distress, or in carrying out physical interventions. There would be oral routes, single medication where possible, at the lowest possible dose. Every 24 hours you should be reviewing their medication, every 24 hours. Haloperidol is what we would give. Risperidone you can give. Olanzapine, that is actually quite commonly used nowadays. Quetiapine and lorazepam. Now lorazepam is given only if the delirium was actually because of the withdrawal of the sedatives or the benzodiazepines. Okay. So earlier on we had discussed what happens if you cannot distinguish between the diagnosis of delirium, dementia, or delirium superimposed on dementia. Yeah? The treatment principle is treat delirium first. And if the delirium does not resolve, then you re-evaluate for an underlying cause. Maybe you miss the cause. And then follow up and assess for possible dementia. Right, any questions?
It's just a comment that was really helpful. As you say, I had a gentleman from Alderney, and that's another factor. He fell, he said, and was rushed over here on his own without even familiar clothes, and it's very difficult. His partner did try and get over, but lack of flights and boats and the costs, etc. And I know he became very agitated and actually started hitting the staff. He didn't know where he was. You know, his partner wasn't there, and he was put on haloperidol and risperidone and things. Initially, they started to walk him with the physio, but then, as I said, he became quite sleepy. They sedated him in order to stop the agitation and hitting the staff. I understand that. And then when I went to, he was in hospital for a very protracted period, getting more and more agitated, missing his partner, who came over several times when she could at great personal cost. And they did that. And the ward couldn't even wash his clothes. She had to take back dirty clothes back and forth, and and she was an older lady too. And also, when the last time I saw, one of the times I saw him, he was sitting out in a chair, but there was a sensor mat. So any time he tried to get up, it started, and he was in a bay, so it was sort of an alarm. And I don't want to be critical. I'm not a nurse. I'm a social worker. But they said we're screening for delirium. I thought, what is that? A blood test? How can you tell? And you said it's not an exact science, is it? You know.
So that sounds like a textbook case of how not to treat delirium.
And also this thing about reassuring. I'm not going to name the person, but a senior management within the hospital said, well, why haven't you put him into long-term care? He's home now, and he's much better. He's home with his partner, and he has improved. You know what I mean?
Yeah.
But it was quite an experience both for him, his partner, and for me to watch that.
Yes, I can.
I have every sympathy with the nursing staff. You know, they don't have the time.
Yeah.
You know, and stuff. And I mean, his wife, his partner, persistently send him home. Said, oh no, we want to, he's not right. He should go into care and all this sort of thing. But eventually, he did come home. And he's doing really well.
And they probably found the underlying cause. They treated it. The delirium went away, and he was settled after a while. I'm assuming that's what happened. And that, like I said, is the textbook case of how not to treat the patient initially. But once he was in the hospital, they kind of got it right by treating the underlying infection or whatever it was. But imagine the impact that it had on the patient, on the staff, on the relatives, on that. And it could have been easily avoided. It could have been,
He was crying.
And next time,
It was very sad to see him. But I'm just thank God he's better now. He's back in his own home. You know.
and once you actually are aware of what you're looking for, it's so much easier to pick these patients. So much easier. Yeah. So, quick. Yeah.
As occupational therapists, we're often asked on the wards to, do some sort of functional assessments or other assessments for their cognitive behaviour, and we've always been battling against what we thought might be delirium, because it is not fair, it's a temporary situation. But if it continues on and on, is there at the end result are people with longer term delirium presenting much as other cognitive?
So there was a slide there. So there was a slide here just at the end that actually said, first of all, if the delirium does not resolve, maybe there's another underlying cause. But if you have ruled out all the causes, then maybe it's dementia. That answers your question. But now, next time they ask you to do these kind of assessments, take your 480 out, start taking it if they are doing all these things, and then combine the 480 with the clinical judgment and tell them this is what I think. Yeah. So a quick recap of what we have discussed. You know the patients who are at risk when they are admitted within the first 24 hours. Please reassess them about delirium. You know how to assess them now with 480. It does not have to happen within the first 24 hours. It can happen any time during their hospital stay, but you know how to use 480. Please use that. Use that with the risk factors, with the clinical judgment, and then manage it. Manage it. Your input is more crucial than anybody else's in the MDT. You would be working with all sorts of things like pain, infection, environment, family. You'll be working with all of them. Only when it is not manageable, then you ask the doctors to intervene and give them medications. And if it does not resolve, then the doctors need to reevaluate the cause and also look if it's dementia. If a patient has got dementia and you think that they're becoming delirious, please focus on the delirium. Don't go for the dementia first. Yeah? You raised your hand.
I was just going to share that I work in a surgical ward, and 480 is part of our admission process. So it's in the form.
Excellent.
And we can reevaluate it anytime as necessary or every week.
Excellent. Okay.
Yes, I was going to say it's part of, for those who know, it's part of the SCAPE audit, should you, that dreaded word escape. It's very much part of what we do and what Jenny and I assess as we go around the wards to see that you have actually completed a 480. But I think it's really what you were just highlighting there, though, Ambreen, is that's not just something to do within those 24 hours. That's at any point during that time where you see that decline, because you very clearly pointed out it fluctuates. It could come, at any stage in their patient journey, particularly when you consider we're having people in the acute setting who are here for weeks and weeks and weeks potentially because of the difficulties we have with discharge. So don't think, I guess the message is, and you can correct me, don't just think 480 is the one time we do it. It's the one assessment we do and that's it, we're done. Because it shouldn't be, should it? Because if somebody's showing any signs of some sort of cognitive fluctuation that seems a little bit odd, the first thing at our disposal is that 480. Grab it, reassess, reevaluate, and consider your picture from there. I will be corrected if I need to be. But hopefully that was right.
No, absolutely fine. So now sorry, was there another question?
I was just going to add as well that the news, the observation, and we use the new scoring. We also have confusion. If there's a new confusion, we score it highly 3. So that's also another.
Okay. In the NICE guidelines, I did not see news. Yeah, in the NICE guidelines, I did not see news as a recommendation for screening for this. Perhaps I know that you do news for patients anyways, but I think for anyone that you think is going through this specifically, then it should be 480.
Yes. also I was thinking of the new confusion. If a patient is new, there's new confusion in the patient. It's a flag.
It is a flag, yes, yes. And then you would go to 480. Yeah. Okay.
Yeah, that's right, because the news kind of highlights, doesn't it, the option. Has this person got some new signs of confusion?
that's
So
a good
yeah,
point.
new signs of confusion on your news, pull out your 480, make another assessment. I think that's a good point.
That's a good point.
Although it's
Yeah.
not part of the assessment for delirium, it's a good way of looking at it from you're doing those general observations regularly, routinely, doing your news. You see something on your news and you go, let's revisit.
Now, if people could fill out my feedback form, that would be great. And
The people on Teams are not getting away with it. I've just sent them a message saying I have some feedback forms. I will send them electronically.
okay.
Um,
I wanted to ask, do you feel more confident now about delirium? Yeah, okay, that's good, that's good. And if there are any other topics that you guys think that you need help with, and if it's related to psychiatry, please do let me know. We'll be very happy to take it.
any sessions that you've just heard it there.
Yeah.
Dr. Malik is very keen to help us, to help increase our knowledge. So if you've got any thoughts, please send them to me, some ideas about what might be helpful, particularly, obviously, Dr. Malik's speciality is psychiatry, so anything that related, which quite often for those in the acute setting is the bit that kind of they're more uncomfortable with, so maybe there is. Please let us know and we will gently twist her arm and I'm sure she'll come and help us again.